Assalamu alaikum wa rahmatullahi wa barakatuh. Hi, and welcome everyone to the Gulf Amyloidosis Club, the one forum where you can hear about the latest and greatest in amyloid science. Anything that has to do with diagnosis, treatment, and patient outcomes, you can find it in this forum. My name is Firas Al-Badareen. I'm a cardiologist from Cleveland Clinic, Abu Dhabi, and I'm the head of the imaging working group of Emirates Cardiac Society. If you've been following this series, we've covered everything starting from epidemiology of the disease, genetic abnormalities, genetic screening. We've spent time on the diagnosis and the role of radionuclide imaging. And today, I take you through treatment. Once you've diagnosed these patients, how do you treat these patients in ways that improve their health status and improve their outcomes? For that purpose, we have two master clinicians, excellent speakers who will help us go through this process. As always, we'll allow each presenter to do their presentation. We'll have 5 to 10 minutes of Q&A after each presentation, and we'll try to wrap it up all in 1 hour. Before we start, I would like to encourage all of you to send your questions through the group chat. And I really want to thank our sponsors, AstraZeneca, who make this kind of activity possible with their support. So without further ado, we're going to turn it over to the first presenter, Dr. Hadi Skouri, who will discuss the role of heart failure therapies in patients with ATTR cardiomyopathy. Dr. Hadi needs no introduction. He's the head of the heart failure section at SSMC, and he's an active member throughout the region. And most recently, he was promoted to a very big post at the Heart Failure Association of the European Society of Cardiology. Hadi, the floor is yours.
Good evening. Thank you, Dr. Firas, for the kind introduction and also for the invitation. And I want to congratulate you on this important series to learn more about cardiac amyloidosis. Excellent job. So Dr. Firas has called me a couple of weeks ago to discuss the heart failure management in patients with cardiac amyloidosis. This is a challenging topic, and I would like to I am going to cover it with Dr. Al-Harari, who will be the second speaker. You all know that two types of amyloidosis, the ATTR and the AL light chain cardiac amyloidosis, these two main subtypes are the most prevalent, and these involve the heart. So, causing cardiac amyloidosis, which is a specific form of an infiltrative heart disease. And when the heart is involved, it can present as asymptomatic LV dysfunction or heart failure and recurrent heart failure hospitalization, or can present with conduction disorders like AV block necessitating pacemakers, or arrhythmias like most commonly atrial fibrillation. Not all of these manifestations are present in every patient with ATTR cardiac amyloidosis. Just here to show you that there are multiple domains of non-specific treatment in ATTR cardiac amyloidosis, from atrial arrhythmias and prevention of embolic events, ventricular arrhythmias, valvular interventions, as well as conduction disease. But our talk today about management of heart failure. Heart failure is considered the primary manifestation of in patients with cardiac amyloidosis, especially ATTR cardiac amyloidosis. It may be present in most cases. 10 to 15% of all hospitalized patients with elderly with HFpEF, they may have cardiac amyloidosis, especially when they have a thick ventricle. We don't have a lot of studies on heart failure with reduced ejection fraction, but it's present. Some patients, they present with a reduced ejection fraction less than 50%, and mostly they occur in the variant type of ATTR cardiac amyloidosis. The clinical presentation of heart failure can vary from diastolic dysfunction, only discovered by echocardiography, LV dysfunction, and diastolic abnormalities, to heart failure with preserved ejection fraction, and less likely we are seeing heart failure with reduced ejection fraction. So when we talk about non-amyloid medical therapy in amyloid heart failure, we have to discuss heart failure. We have to discuss other issues like aortic stenosis and arrhythmias, etc. But today our talk will just be concise to heart failure management. One thing that I can summarize all my talk is that there is a lack of evidence about guideline-directed medical therapy in heart failure patients with cardiac amyloidosis. So up till now, we don't have trials, randomized trials to study these treatments in heart failure in cardiac amyloidosis. So this is why it's challenging. So no randomized trial supporting a prognostic benefit of either beta blocker, ACE inhibitors, ARBs, MRAs, in addition to SGLT2 inhibitors, as well as new therapies like GLP-1 receptor antagonist and non-steroidal MRAs. Patients with non-ATTR cardiac amyloidosis, actually, they were excluded from trials of conventional heart failure therapies. So this is why assessment of safety and efficacy has been limited to just observational, small-scale, and retrospective trial. Just to summarize here, the most important landmark trials in cardiac amyloidosis. These are three trials: the ATTR ACT, the Attribute, as well as the Helios B. And we can see that in the first one, SGLT2 inhibitors and mRNAs were not used in the treatment, neither at baseline or during treatment. But we can see, because these studies were after 2021, 2022, so we are seeing more and more patients are on MRAs, up to 34%, and more patients are on SGLT2 inhibitors. And if they are not on baseline, during treatment, there is a prescription of these medications, with MRA can reach up to 23% increase in prescription, and SGLT2 inhibitor around 13.3%. But at the same time, we know this restrictive cardiomyopathy is challenging. And usually with ATTR cardiac amyloidosis, we have biventricular restrictive myopathy, the right ventricle and the left ventricle. And this is why we have some challenges, because we have a fixed stroke volume, we have conduction disorders, autonomic dysfunction. These patients may have hypotension, and we know that all this treatment can cause low blood pressure. They have very sensitivity to fluid homeostasis, and they have decreased functional capacity. At the same time, and on the other hand, these were excluded from clinical trials, and at the same time, this diagnosis is becoming more and more prevalent. So we have a lot of challenges on one hand, but at the same hand, we have more prevalence of this drug, and we have limited trials on guideline-directed medical therapy. So I will go with you over some of these management. Diuretic is a mainstay when we have volume overload. Sometimes we have in these patients diuretic resistance. We may have to escalate treatment, but what's important is they are sensitive to diuretic. They are sensitive to preload, and this is why overdiuresis can cause hypotension and low stroke cardiac output, and underdiuresis they remain congested. ACE inhibitors and ARBs, ARNIs, beta blocker. We'll go briefly on SGLT2 because Dr. Harari will discuss it further, and I will touch briefly on the new treatments of HFpEF, finerenone, and GLP-1 receptor antagonist. Just going back to old days of 2017, this is one of the trials, and they are asking, is it useful to use standard heart failure medication in cardiac transthyretin and cardiac amyloidosis? They prescribed here beta blockers and ACE inhibitors in 480 patients with wild type and variant type, mutant type of ATTR cardiac amyloidosis. Actually, in the wild type, there was no difference if these patients were on beta blocker or not beta blocker. But in the mutant type, in blue, patients who were not on the treatment arm, whether ACE inhibitors and beta blockers, those who are not on the treatment arm, they have a better survival than those that were treated with. So this is important, especially in this mutant form, because they have autonomic dysfunction, autonomic dysregulation, more hypotension episodes. But from this study, we have seen that better if they are not on. This is another trial on beta blockers. Over of 106 patients with ATTR cardiac amyloidosis, they are on beta blocker for different reasons, for AFib control, for ischemic heart disease. Just taking these patients and stopping beta blocker, discontinuing beta blocker in these patients, actually their BMPD has decreased, but was not, there was a trend to decrease, but was not significant. But what is important, their 6-minute walk test improved significantly. Their heart rate increases for sure after stopping beta blocker, but their functional status has improved also significantly. So discontinuing beta blocker in these patients, the patient felt better. So this is another thing that I want you to keep in mind while going on with discussing these managements. This is from the Mayo Clinic proceeding, which was published in 2022. So they took 128 patients with ATTR cardiac amyloidosis from 6 centers in Spain. And actually, patients who were on beta blockers, they did better than patients who were not on beta blockers. So in this real-world prospective multi-institution registry, patients with ATTR cardiac amyloidosis who received beta blockers had a lower all-cause mortality than untreated controls. So we started to have some controversy in these patients. We know that this is a small number of patients. And actually, if we look at these patients, 25% they have withdrawn beta blockers over follow-up. And this is due to several reasons, mainly bradycardia, hypotension, etc., fatigue. So even though they are on treatment, not every patient can tolerate treatment in these patients. We know about the TopCat trial in heart failure with preserved ejection fraction that was a negative trial. They just took in this trial patients who are maybe resembling cardiac amyloidosis or have the same characteristics of cardiac amyloidosis. There were 135 patients who have their S prime less than 6 centimeter per second and interventricular septum more than 12 millimeter. Actually, in this group, you can see who have less than 6 and more than 12 millimeter, they have the worst prognosis. But if they were on MRAs compared to non-MRAs, actually they do the same. They improve as that of MRAs in the other groups. So patient with interventricular septum more than 12 millimeter and S prime less than 60, resembling that of ATTR cardiac amyloidosis, significantly these patients were more likely to experience the primary outcome as that of the rest of the cohort, meaning that MRAs may benefit these patients in a way. This is one of the largest retrospective trials that I am going to dwell with you from the National Amyloidosis Center. From 2000 till 2022, over 2,370 patients with ATTR cardiac amyloidosis. The aim of this study were to assess prescription pattern, dosages, discontinuation rate, and association with prognosis of the conventional heart failure medication in patients with ATTR cardiac amyloidosis. I will show that in the summary at the end, but let's start with beta blockers. Overall cohort, patients on beta blockers or no beta blockers, they have the same effect. There was no improvement in survival. Patients with AF more than 40%, also there was no improvement in survival. But patients with an AF less than 40%, actually in red, patients on beta blocker, they did better than those or not on beta blocker. So up till now, we have some evidence that in patients with cardiac amyloidosis and reduced ejection fraction, beta blockers can have some benefit in these patients. When it comes to ACE inhibitors and ARBs, whether less than 40% or above 40%, there was no benefit. When it comes also to MRAs, there was benefit as in the overall cohort, but this benefit was driven by patients with an EF more than 40%. So half PEF or half mildly reduced EF with cardiac amyloidosis, there is evidence that patients on MRAs, they may have improved survival in this population. And this is the summary here showing that with beta blockers low EF, they have better. ACE inhibitors, there is no benefit or ARB, and MRAs, there is benefit in half PAF patients or mildly reduced or preserved ejection fraction. There is another study published in Journal American Heart Association in 2021 where they included 309 patients with ATTR cardiac amyloidosis with a mean age of 73, 84% were men, and around 17% were on atrial fibrillation. 49% were on beta blocker, 35% were on ACE, and MRAs were on 23%. You can see that on follow-up, there was significant reduction in beta blocker use to 17%. Also, there was a trend to have missing beta ACE inhibitors, while MRAs has increased because it's being more tolerated in these patients. And more newly, MRAs patients were treated during follow-up of these patients. What's important here with beta blockers, there was no significant difference except when we tried to withdraw beta blockers in these patients. Patients who continue beta blockers, they have a worse prognosis compared to those they stop beta blockers. So stopping beta blockers, they did better on survival in these patients. While ACE inhibitors or MRAs, they didn't have any difference in treatment in this population. So what we have learned here is that although it's believed that the traditional heart failure therapies may either cause harm or not be well tolerated in patients with ATTR cardiac amyloidosis, there are limited data evaluating this. And the current study here, we demonstrate that there doesn't appear to be an association of traditional heart failure neurohormonal blockade with survival. So either benefit or harm in a trans and cardiac amyloidosis, except for beta blockers. If we stop them, they may improve survival. Just few points, and I'm sorry, Dr. Harari. SGLT2 inhibitors in a small study of 220 patients compared to the matched cohort study, they found that they are well tolerated, safe, discontinuation rate is very low, and they are associated with lower mortality rate and better cardiovascular outcome with slower decline in kidney function. This is a systemic review and meta-analysis too, showing that it has more effect on heart failure hospitalization, arrhythmias, mortality, and MACE too. This will be discussed further, but also ARNI, we know that Entresto or angiotensin receptor increasing blocker is like ACE and ARBs, but there is a small study studying 6 patients showing that if we carefully titrate these patients with ARNI, they do better, especially on outcome. But this is a small trial, and we cannot dwell from that except if we have large trials, knowing that they have tendency to have lower blood pressure with ARNI compared to the others. When it comes to finerenone, also there are a couple of abstracts that are being published in 25, 26, showing that in these patients, they are well tolerated and they improve kidney function and some heart failure outcome. And this abstract, it has been shown that it is safe and it has an effect in kidney protection in patients with HFpEF. When it comes to glucagon receptor agonist also in this population, also there are just prospective propensity match analysis showing that in these patients, they have a protective effect on mortality, arrhythmia, and heart failure. But this is no randomized trial, but there are some retrospective studies. When it comes to recommendation by different societies, loop diuretics is recommended in all patients. Beta blocker is not, is not recommended in most, and in some avoid it, except as I told you in reduced ejection fraction. ACE inhibitors also either to avoid or in selective patients. Secondary valsartan, also there is no real data for benefit in these patients. MRA, more tolerated. It's recommended in some like the Canadian and the Japanese and might be considered in the American Heart Association. This was based on different trials that I went with you over them, showing some controversy in some they have more benefit than others, but this is what we have up till now. So in redefining the optimal therapy in ATTR cardiac amyloidosis, when it comes to decongestion, whenever we have volume overload, loop diuretics are important. If we have cardiorenal or we are not able to decongest adequately, we have to combine with others. Natriuresis guided therapy can help, and with the close monitoring, because I am telling you, because of the sensitivity of preload. If we lower more preload, because it's dependent on preload, we will have drop in stroke volume, hypotension, and symptoms. MRAs and SGLT2 inhibitors are better tolerated with some beneficial effect in these limited retrospective studies. There are some conditional warning on beta blocker, especially used in reduced ejection fraction, and still data on ACE, ARB, and ARNI doesn't favor any survival or other than survival benefit in these patients. So in different reviews and consensus document, they all mentioned advice for SGLT2 and MRA because they are well tolerated. Beta blocker in selective patients, still in the others, either not advised or there is no data. This is a consensus document by the published in the American College of Cardiology by the ACC, showing that volume management is important in these patients. When it comes to heart failure medication, MRAs and SGLT2 inhibitors, they have a strength 3. May be appropriate to use beta blockers less than 40, but advised not to do with ACE, ARB, or ARNI unless the patient is hypertensive or have a compelling indication. So different studies, different consensus paper with the same message. SGLT2 inhibitors and MRAs, they have more benefit in this population, waiting more randomized trials. I think I will stop here. And if there is any other questions during the questions about any practical message of the diuretics or how to start these medications, I am ready to answer.
Thank you so much, Hadi. That was fascinating. That was totally impressive, comprehensive review, and I really, really enjoyed it thoroughly. Let me see if there are any questions in the chat. Please feel free to share any questions with me, Abdullah. Let me ask you, Hadi. So you've made elegantly the case that when a patient is diagnosed and they have established phenotype and they have normal ejection fraction, we probably should not be starting them on the standard GDMT, beta blockers, and ACE inhibitors. Is that correct?
So yes, if they have normal ejection fraction, there is no evidence that ACE inhibitors, ARBs, or ARNIs and beta blockers, they have benefit. Actually, withdrawing beta blockers, if they are on beta blockers, they did better, these patients. And the harm that we are doing in these patients, especially in the variant type or the mutant type, is because they have autonomic dysfunction, more neuropathy. They may have more hypotension in these patients. And one of the recommendations that I have encountered, and I am using it in some patients, is using midodrine. In the American College of Cardiology paper consensus document, they recommended midodrine in these patients, especially with autonomic dysfunction, to be able to start treatment of beta blocker and ACE inhibitors in these patients with low ejection fraction if they need it.
Okay, fair enough. So let me ask you the reverse scenario. If a patient arrives in your clinic on beta blockers and on ACE inhibitors, and they have a phenotype but with preserved ejection fraction, and another patient with reduced ejection fraction, will you keep them on the medicine? Will you stop the medicine? in both patients, in one patient but not the other? How would you handle these two scenarios?
Okay. If patients are hypertensive, I will keep the medicine on them. If patients are having low blood pressure or borderline blood pressure, I will remove the ACE or ARB on them and the reduced ejection fraction patients, and I keep beta blockers on them. And the preserved ejection fraction, if they have low blood pressure symptoms or soft blood pressure, I will try to withdraw one of the medication first and reobserve. What medication to withdraw first? It is a difficult question. There is no data on both. There is no randomized trial. It depends. If the patient is on the bradycardic side, I will try to stop beta blocker first because we need some heart rate in these patients because they have a chronotropic incompetence. And studies have shown that withdrawing beta blockers, we may improve their quality of life.
Super, super. Thank you. This is very clear clinical pointers that you shared. Let me ask you another question. You've also very clearly highlighted the gap in the evidence. We need randomized trials. There are a lot of observational studies with some residual bias, but that's what we're going by. If you and I are sitting on an advisory board and we are designing the next RCT in ATTR cardiomyopathy, what do you think the first agent that we should be studying? Is it beta blockers, ARNI, SGLT2 inhibitors, or GLP-1 receptor agonists? I know there is no right or wrong, just kind of to discuss.
I think the ones that should be studied in cardiac amyloidosis, have PEF cardiac amyloidosis, let's say, SGLT2 inhibitors and non-steroidal MRAs and GLP-1 receptor antagonists, whether combined or each alone, but they have to be studied. I think they will start with each alone, I think, and then they will see what happens. But we should have a pragmatic trials already. We have patients already on treatment, so pragmatic trials already, like real life world prospective studies that will help us see these patients how they are behaving on long term on these medications.
I agree with you that the data and the science behind SGLT2 inhibitors and potentially GLP-1 receptor agonists is compelling in HFpEF. Whether it will hold true in ATTR or not, I think I'm optimistic, but what we really need high quality evidence.
Yeah, because it's an infiltrative disease at the end. This is a different pathophysiology than HFpEF by itself or HFrEF by itself. So I'm not sure how much these will contribute to the pathophysiology of this infiltrative disease, or they will be working on the mechanisms of volume depletion plus minus some vasodilatory effect.
Okay. We don't have any questions from the audience. Any last comments, Dr. Hadi?
So basically, up till now, just to summarize it, with cardiac amyloidosis, heart failure, management with heart failure guideline-directed medical therapy is still limited. There is more evidence on SGLT2 inhibitors and MRAs that they are well tolerated, better tolerated, and they may have improved in their survival. No evidence on ACE/ARB or ARNI, with limited evidence of beta blocker in the lower blood pressure group and the lower AF. But there is evidence by a couple of retrospective trials showing that stopping beta blockers, they may improve the quality of life of these patients.
Super, and I really want to thank Dr. Hadi for this very comprehensive review and for his clear clinical pointers. And I want to make a pitch to if you end up suspecting cardiac amyloidosis, if you have a diagnose a patient with cardiac amyloid, whether ATTR or AL, this is really important that this patient be evaluated at a center of excellence for amyloid because of these nuanced decisions that you have to make. So Dr. Skouri at SSMC, Dr. Al-Harari at CMC run heart failure programs and have special interest and expertise in cardiac amyloidosis. So they are there to help and rescue. Hadi, thank you so much for your time and your contribution. Moving along, next I'm introducing a friend and a colleague, Dr. Muhammad Al-Harari, who heads the heart failure program at Sheikh Tahnoun Medical Center. And he will build up on the elegant background from Dr. Hadi and will specifically discuss, is there a role for SGLT2 inhibitors in ATTR cardiomyopathy? Muhammad, take it away.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Really thanks a lot, Dr. Faras, and I echo what Dr. Hadi said, congratulating you on your really fantastic program and the audience you're managing to attract because of the quality of the program you put together, and thanks for the introduction. I don't think Dr. Skouri have left much for me to say, really. I think he covered it all. So he made it easy for me. I just go over a few things to be mostly repetition. And my talk was actually made even easier in a way because you, Dr. Faras, just suggested a paper to me. So I looked at it and I basically sort of studied it and I put it in a presentation. That's all what I'm doing. So apologies if it's boring and apologies if it's a bit short. So my task is to talk about the role of SGLT inhibitors in ATTR cardiac amyloidosis. So let me just move this. So this is the paper, really. So this is basically a meta-analysis of the use of SGLT inhibitors in ATTR cardiac amyloidosis. And this is really the first ATTR-focused meta-analysis. You've heard this already. So on one hand, in ATTR, we have a clear, disease-modifying, improving survival therapy that's coming on, the stabilizers, the silencers, etc., etc. But obviously, access is not that easy for them, cost-wise. On the other hand, we have a therapy that's been proven to be very effective in heart failure, generally with HFrEF or HFpEF, among those SGLT inhibitors with clear evidence, really. The issue is, as Dr. Hadi has alluded to, that these cardiomyopathy, ATTR cardiomyopathy, were excluded from these studies. So these agents were not really studied in any randomized trials in ATTR cardiomyopathy. So the question is, and the answer already provided by Dr. Skouri, do we have any convincing or evidence that suggests that these agents work or change the course, not just only the symptoms? So as you heard, as you probably know, amyloidosis is an infiltrative disease. So it makes your ventricle stiff, which is really a problem. So it doesn't really relax, at least in initial stages. So you got like a thing stuck there. So your cardiac output relies on your heart rate. So if you really make your heart slow, your cardiac output will drop, as you heard, and withdrawing the beta blocker make these people better. But also because your heart is stiff, it makes it very, very sensitive to preload and afterload. So if you are congested, if you have a lot of fluid in board, you really become symptomatic. If you drop your afterload, you really drop your blood pressure, you drop your cardiac output, you become hypertensive, you feel dizzy, you black out. And also to combine this, you have an autonomic autonomic dysfunction. So it's really tricky. You get like a stiff thing there that you really need to handle carefully what medication to give, what medication you shouldn't give, fluid states, decongestion, etc. So as you hear, beta blocker are really poorly tolerated, and really shouldn't be given. We're talking about HFpEF here. The ACE and ARB because they're vasodilators. So really they become hypertensive. They drop your afterload. You become dizzy, blackout, whatever. Poorly tolerated. MRA probably well tolerated. You heard some evidence from Dr. Scori that probably they are okay, but again we don't have survival benefit. So the question related to my presentation, do SGLT2 inhibitors really improve not only the symptom, but do they improve the cause? Do they have any disease-modifying benefit that we can have evidence for? So that's what we'll try to answer just by going through this paper that actually has screened initially, looked at 294 studies, and of those they came up with 24. The rest were excluded because either they duplicate or abstract or they lacking outcome of interest, etc. And out of these, they came down to only five trials that have actually a meaningful sort of random, in a way, placebo, not placebo, but SGLT inhibitors versus no SGLT inhibitors and ATTR cardiomyopathy. 5 studies, but good number, 5,000 patients. But remember, these are observational studies. Okay, they are not randomized trials. See, these are the studies. Look, first, there's a variation in the number of patients. The majority come from Jaswal study, 2024. Variation in the follow-up, 3 months to 36 months. So what is the outcome? I'm not going to go through the design, whatever, but of the studies or method of analysis, but just coming up of what did they find? What did they come up with when they looked at these 5,000 patients and those 5 studies who were half of them were on SGLT inhibitors, half were not on SGLT inhibitors. They all have ATTR cardiomyopathy. The majority were wild type, by the way. So what did they find in the follow-up, which is variable, as we really mentioned? 63% reduction in all-cause mortality. Very impressive, almost unbelievable. So when you get SGLT inhibitors, you get 63% reduction in mortality, all-cause mortality. More so, 70% reduction in cardiovascular mortality. Wow. Significant reduction in your NT-proBNP, significant reduction, 41% reduction of hospitalization. So quite impressive, symptomatic in a way, decongestion and readmission to hospital, signals of significant reduction in all-cause mortality and cardiovascular mortality. And was very well tolerated, less than 10% risk of discontinuation, which is not surprising knowing SGLT inhibitors and this very tricky, hemodynamic, difficult to manage type of HFpEF for the amyloidosis. What the study found, or the author was found, that in these studies, the majority of patients who had SGLT inhibitors were actually the sicker ones. So there's sort of a selection bias. So basically, we are, as a doctor, we tend to give SGLT inhibitors more to the more symptomatic, the more with higher NT-proBNP, the more with the worse eGFR, etc. But we still get, significant, based on the study, reduction in mortality, whether cardiovascular or total mortality, in addition to the readmission and decongestion. So these are the findings of this study. So it's an observation study. It's a meta-analysis. A huge number of patients, half on SGLT inhibitors, half not. They all ate ATTR. The majority were wild type. Based on this observational study, they found that these people on SGLT inhibitors, they are less likely to die, less likely to be hospitalized to hospital. Very impressive. But also, as we said, probably other factors, because it's not a randomized trial, confounding factor, the selection bias, one of them like use SGLT inhibitors in more sick patients. Quite varied follow-up. Some study ended at 3 months, some 3 years. Variation in the number of patients in each study. So that also, and the some indication bias, as you said, that they are SGLT2 were given more to the sicker ones. The studies, the analysis would seem to be results mostly driven by one of the studies, which has the largest number of patients. That 70% mortality really makes us, even the author said, this is really too massive to reflect a true clinical benefit from just because GLP-2 inhibitors. There are other factors probably involved. So what can we conclude? What can we come up from all this? Not having no randomized control trial in CLT inhibitors, that it is safe and ATTR cardiomyopathy, and a message already passed early on by Dr. Hadi Scory, and they are beneficial, at least in the congestion and reduction of hospitalization. The mortality is probably too good to be true, sort of. And obviously, the recommendation is to use it as adjunctive, not as a disease modifying, i.e., not anybody as soon as you diagnose them with ATTR, if they are even if they are completely asymptomatic, you put them on GLP inhibitor because it changes the outcome. But you use it if they are having symptoms, they start congestion, if they have the edema and T-brom B, whatever, elevated, and also it will help you to reduce the diuretic, which probably they will need. Diuretics are more likely to reduce your upper load and afterload, and more likely you become symptomatic due to overdiuresis. So that gives you that balance. And it is not a guideline endorsed, of course. And what we need, we need a randomized trials to define their rules, as we probably need further. But as the answer to Dr. Firas earlier on, for me, SGLT2 inhibitors, and probably as Dr. Hadi Scory says, non-steroidal MRA and possibly GLP-1 agonist, maybe aldosterone synthase inhibitors as well. Probably the one could be tested on these patients. And I'm probably going to end here. So short, done.
Short and sweet. Thank you so much, Dr. Mohammed, for your critical appraisal of this trial. Pretty impressive effect size, isn't it? 65 to 70% reduction in outcomes. That makes you almost think it's unethical not to treat these patients or ATTR cardiomyopathy patients with SGLT2 inhibitors. My question is, do you believe that SGLT2 inhibitors are beneficial in this cohort, in this population? And if they are beneficial, do you think the effect size is that big, or like you said, it's an overestimate? What do you think, Dr. Muhammad?
Well, I go with what the author himself concluded. That's probably an overestimate of the truth, but there is some truth in there. In addition to the symptom, those patients tend to be better. They give them to the sicker people, and they get significant benefit. And if I had an amyloid, and most of the amyloid we tend to diagnose to probably have symptoms, so I will definitely be one of the first line plus an MRA or non-steroidal MRA until we have the evidence that's on the contrary, which is unlikely. Having a randomized trial is the one we desperate for, but will it happen or not? Not too sure.
I agree with you. Hadi, any thoughts whether or not you believe that SGLT2 inhibitors are beneficial in this population?
I was just thinking that already we know that in patients with cardiac amyloidosis, when they are diagnosed, they are already, most of them, they are first diagnosed with heart failure with preserved ejection fraction before they have been diagnosed with cardiac amyloidosis. So most of these patients we will encounter, they're already on some SGLT2 inhibitors. So on these patients, they have to be continued. Patients who are not on SGLT2 inhibitors, after starting disease-modifying therapy, I think whether they are diabetic or not, there is no harm in starting them, showing that even though this is limited trials, they are safe and they can be beneficial. At the end, this is a complicated and challenging diagnosis in these patients with multiple, let's say, outcomes like not only mortality, hospitalization, and quality of life. So if we improve any of these, will be a plus also to the overall care of the patient. So if they are safe with less side effects, and reduced the one thing that I showed, that only 4.5% they withdraw therapy during treatment, which is it's well tolerated. So I think I will go with that in the time being. Yeah, if I
I
want to
agree with you.
compare SGLT2 inhibitor, AMR is the
Yeah,
second.
yeah, yeah.
I agree with you. Go ahead, Muhammad. I was
No, I
going
was
to
going to
keep.
say, I would just say, I would just treat them as, to be honest, as a HFpEF, but I will not give them Entresto. I will not give them beta blocker, and it will be SGLT2 inhibitors plus MRA, probably non-steroidal.
Yeah,
So
just
we
to
are
make a
not
couple of
going to treat them with RAS activation, and it's not the same theory, pathophysiology.
Yeah,
just to make a couple of methodology points. Keep in mind that Dr. Harari already highlighted that this is a meta-analysis of observational data. So you have confounding and you have bias in this study, and when you combine the studies that each has its own bias, you just amplify this bias even further. So I suspect that the effect size is much smaller than what was reported in this meta-analysis.
yeah.
Uh, However, I believe that SGLT2 inhibitors are advantageous. The one study that was mentioned by Dr. Hadi, which used the propensity score matching, it tries to some extent to balance the populations and get as close to randomization as possible. It is still non-randomized, still observational, but it makes the patients statistically identical to the point that the only difference between the two groups is the intervention. SGLT2 inhibitors here, no SGLT2 inhibitors in the other group. And even in that study, there was signal for benefit. So if anything, I think this is beneficial, maybe not as too good to be true as shown in this meta-analysis, but at least worth a try. That's my personal take, to be honest.
Yeah, concur on that, absolutely. Yeah.
Let me ask another question to both of you, not to belabor the point. A lot of the data that talked about withdrawal of GDMT, continuation versus withdrawal, doesn't really mention or differentiate whether the patient presents early on in their ATTR journey or late when they have class 3 or class 4 symptoms. When they are late, I think it makes more sense that withdrawal may be better. But do you guys think that the same signal and same advice applies in patients who present early on, especially in this era where we will be looking at patients after carpal tunnel surgery, patients after asymptomatic genetic mutation? So we are likely moving upstream in terms of diagnosing these patients. Does the same wisdom of withdrawing GDMT apply to these patients? I would like to hear the thoughts from each of you.
You mean that somebody diagnosed very early and he's on, we took ATTR amyloid and he's on SGLT2 inhibitor, for example, MRA, whether you stop or not? Is that the question?
Whether you start them on SGLT2 inhibitors and
Yeah.
whether you withdraw ACE or beta blockers, for example. They have preserved LV function, they have thickness, and they have an abnormal PYP scan. Would you
Yeah.
treat them? Would you withdraw therapy? What would you do?
I think in relation to the beta blocker, ACE, ARB, and RE, keep them only if there's a strong indication for their use other than the ATTR cardiac amyloidosis. And if they are really hypertensive, and yeah, probably well, particularly ACE, ARB, and RE. Whether starting, if somebody say, I said you put the example of bilateral carpal tunnel syndrome, and incidentally find a little bit of LVH, and you confirm, and you started the disease modifying agent of MES, whatever, completely asymptomatic, no other indication, probably you wouldn't. Even a CO2 inhibitor, I don't see it. Hadi?
I don't know what the right answer is either.
No.
Uh,
Hadi, what do you think?
This is one of the gaps that has to be answered. So one of the things that has to be answered is to differentiate between different stages of ATTR cardiac amyloidosis. This is very important. But if you come back to the pathophysiology of cardiac amyloidosis and the infiltrative disease, uh, ACE inhibitors, ARBs, are not going to improve remodeling in these patients. So I will not start them in these patients that they are asymptomatic and the pathophysiology is different. So I will not go with that choice. Up till we have more evidence, ACRB and beta blockers for an asymptomatic with no compelling indication, I will not go, except that the patient is hypertensive or tachycardic or AFib to start beta blocker on these patients. Otherwise, I will not start. In advanced stages, and this is where we are seeing these patients, most of the patients that are studied are in advanced stages, most probably. And this is why withdrawal, they do better in these patients. But in the early also initiation, there is no evidence for me. ما بعرف.
Yeah.
Clearly a controversial area, a gap, as you guys indicated. How about we went quickly over diuretics? Do you have a specific, when these patients come to your clinic, do you address diuresis in these patients differently than you do in other heart failure populations, Hadi and Kamran?
Yeah, for the sake of time, I didn't go over diuretic that much, but as I said that patients with volume overload, they should be diuresed, and it's recommended, but they should have a close observation in diuresis because of this small window. Any decrease in preload, further decrease in load will cause to drop in ejection and cardiac output and hypotension. So this is where we should closely follow up these patients in order not to have overdiuresis in these patients. I said so. What is the best treatment option in these patients with volume overload? Actually, if they have just volume overload with no right-sided failure and no gut edema or involvement of the gut with amyloid or gut edema, then furosemide is fine. But whenever we have gut edema, we need more absorption of. This goes for torsemide better than the others concerning, or a combination of furosemide with thiazide when we have this cardiorenal syndrome. But if anything, we'll go with torsemide if available. Then bumetanide. Then the third option will be furosemide if we have gut edema in these patients from right-sided. The most important thing is we need to diagnose volume overload on these patients. And it's not only lung congestion. We need to check IVC for venous congestion because of the right side, the volume overload, venous congestion. We need to check the IVC too and the lower extremity edema and from physical exam the neck veins too, so that we can diagnose volume overload. It's not only lungs that will determine if we diurese the patients or not. I will always do a focus or just a minimal ultrasound to check the IVC in these patients. If the IVC is still dilated, I have to keep diuresing them and closely observe them.
Fair enough.
Yeah.
Muhammad?
Well, I think that the important thing that these people with, as far as diuretic, we have to treat them slightly different from others, heart failure, because of the sensitivity to their volume status, preload and afterload. So we have to start slow and increase and monitor closely because you can get them into renal failure if you over diurese them. You can give them hypotension also if you over diurese them. And I will try to obviously overlap the diuretic, the loop diuretic with the SGLT2 inhibitors, and probably I will be tending to use MRAs as well more in order to allow you to use less diuretic and monitor closely clinically by labs, probably by IVC, Dr. Hadi Skouri mentioned. So the difference in treating use diuretic in this patient, you have to be more careful and don't over diurese and try to overlap with other agents that reduce the need for diuretics.
Fantastic. Do you guys ever use parenteral diuretics in clinic? Do you have like diuresis clinics do you find, because there's that one study from Hopkins that they use diuresis clinics and it found that it really mitigated admission to the hospital because, as Hadi said, these patients are frequent flyers. Any experience with that, Muhammad or Hadi?
We do have an infusion in the clinic, and we use it not that frequently for this. And we have a protocol standard. So we see patients in the clinic that we don't think need to be admitted, and we just prescribe them, say, 2-3 doses daily of, say, furosemide, whatever. And we just refer them to the infusion clinic, and we order lab for them before or after and bring them back. So yes, we don't use that that often, but we have it. Yeah, and see them protocolized.
Yeah, I don't have here in UAE any experience in infusion clinic. I'm trying to set one, but we are not able in our institution. But this is a good idea, not only for the ATTR cardiac arrest, but for all patients to prevent rehospitalization too. So this is one study actually just published. We heard about it. Me and Muhammad, we were at the Heart Failure Congress 1 week ago about
Yeah,
subcutaneous
yeah,
furosemide in
yeah.
patients. So maybe this is also could be applied to these patients.
Very impressive study.
Definitely a lot of developments and very exciting space to be in as a physician and as patients as more treatment options become available for these patients. We're getting close to the top of the hour. I've really thoroughly enjoyed this conversation with clinicians par excellence like yourself, Hadi and Muhammad. Thank you so much for your time, sharing your expertise. This has been very informative, and hopefully the audience found it as informative as exciting. We will be back with another episode of the Gulf Amyloidosis Clinic, so stay tuned. And until then, I would like to thank Dr. Hadi Skouri from SSMC and Dr. Mohammed Al-Harari from STMC. And again, my name is Firas Al-Badareen, and stay tuned for the next episode of Gulf Amyloidosis Clinic. Until then, stay safe, and we'll see you all later. Assalamu alaikum wa rahmatullahi wa barakatuh.
Assalamu alaikum.
Thank you, Firas. Goodbye, Hadi.
Thank you.
Thank you.